So a student who comes in knowing nothing and leaves knowing very little has improved, but are they good? Okay, we're not wanting to assess based on improvement. We're wanting to assess against the standard. The singular consideration should be how the level of achievement inferred from evidence compares with the minimum levels required for the different grades. Nothing else. Nothing else. It doesn't matter how much effort a student's put in or how much they've improved. If they don't meet the standard, they're not competent. Standards allow us to measure true competence and leave out the facets that aren't related. So, in conclusion, in standards referenced assessment, it's the configuration or pattern of performance taken over a series of testing episodes and assessment tasks which take precedence. Okay? The holistic image, the big picture. That's what we're looking for. Are they good enough? Have they met the standard? That's what we're looking for. A holistic view of the assessment of student performance is to look at the overall performance of the student rather than a series of discrete incidences and compare this to external standards using our professional judgment. So I'll leave you with that, and I hope that you found that somewhat beneficial. Thank you.
Thank you very much, Andrew. That was excellent. Now, I'm going to ask you, one of the, under the subliminal messages in this is an interprofessional experience, and we're going to have one now. We're about to go out to our morning tea, and I would like to ask us to, no one's going to be required to do anything. I invite you, please, to approach somebody from a different profession, and you have a task to do, and I'll ask a volunteer to report back on how well they achieved the task. I'd like to ask the radiographers to make contact with a dentist here and ask them to teach you over tea how to place a dental implant. Radiographers, I'd like you, so that shouldn't be too difficult. The dentist will teach you how to do that. It's a snap. No one, everyone does them. Dentists, I'd like you to approach a radiographer and I'd like you to ask them to teach you how to achieve a chest x-ray.
There's a dentist who wants to know how to place implants.
No, doesn't apply. Doesn't apply. Okay, so I will ask for a volunteer from both professional groups after the morning tea to report back on, and so I'll be asking a radiographer to stand up here and explain to us how a dental implant is placed, and I'd like to ask one of the radiographers to stand up and explain, and one of the dentists to stand up and explain how a chest x-ray is taken, a decent chest x-ray is taken. Okay? Now, please enjoy morning tea outside, and I'll haul you all back at about 11:20. Thank you very much. But is there a volunteer from the radiographers to explain to us how an implant is done? And the dentists, oh, there is, look, please come forward. And the dentists, in the audience will please give, by a show of acclamation or not, how well she does that. Thank you very much.
Sorry, I had to rush up before I forget everything. But we had a very good tutor in Kenneth, and he said that there were 4 stages to an implant. So the first one is the access, and then there's the preparation, the insertion, and then the closure. So by way of access, there's 3 different methods, and the first one is for the incision and the opening up of the flap around the tooth. Another one is actually for a direct extraction of the tooth. And the third way is with a hole, like a core punch to access. The next one is the preparation. And what you need to do is say you've got a 4mm implant, you have to start with different size drills. So you might start for 2mm and gradually open up the insertion. So that's the access preparation. Then to actually insert the implant, you have to put the implant in, screw it in so that you get good torque and to get the right height of the implant. And the last thing is with the closure, it's either like a plate, but it's the flat closure or the healing abutment. So those two different types depend on how you're going to close it. You either sew over the top of the closure plate or you suture around the healing abutment. Hopefully that was correct.
I'm not sure she's a radiographer. I want evidence.
I'll vouch for it.
Dentist, what did we think of that?
Very good.
Very good. And thank you for the courage in putting your hand up. Now, dentists, come on. I need a volunteer. Come, Nigel.
What I think is fascinating in that is that What I think was fascinating in that is how we all perceive questions and come about answers in different ways. And the sort of answer that my coached radiographer received from me was quite different from which is more on sort of how you assess it and whether it's appropriate for an implant and taking the cone being radiographed, which of course appealed to the radiographer, as opposed to the simple, how do you actually do it, which is, make a cut and put it in. So, yeah, well done, well done. Chest x-rays. I'm going to assume that we have a reasonably healthy patient that can stand in front of the machine, that's not traumatised and has some sort of mobility, because if they don't, it makes things a little bit more difficult and more compromised. The patient needs to have no metal objects in their studs or their bra or pens in their pocket or any other metal in their chest. To stand in front of the, and the patient's going to be standing in front of the screen that receives the radiograph, to try and roll their shoulders forward so that it moves the scapula away from the rib cage. To take a deep breath so they breathe in fully so the lungs are fully inflated. Hold the breath when they take the breath and not to move forward and move back, but not to move their arms back as they take their deep breath forward, keeping their hands away from their chest. I presume. Someone pushes the button quickly and then you can breathe out.
That's it?
I think so. Well, it's a bit like, that's as easy as placing an implant. Good. That's fine. It's fine.
Practical-wise, that's good.
Well, that's all we need.
Talk about the elderly people.
Elderly people who, well, I was assuming there's going to be a healthy person that had the mobility you required. If they don't have that mobility...
How far is the X-ray tube got to be from the patient?
I didn't tell you.
180 centimetres.
I hear 180 from the back of the room. 180 centimetres, that's 6 feet. Right, okay. Thank you.
Well done.
Thank you.
Thank you both volunteers. Now look, that was such, interprofessional learning is far, far more complex and is a pedagogy in itself. But that was just a glimpse of how really the links between us are far stronger than those divisions between us. And certainly as clinical teachers, we're part of one large community that happen to teach within different disciplines. So before I pass over to Rob with his presentation, I invite please Jane Beach from WICTN and HETI, who are the funding body through HWA that made all of this possible. So please, she's going to address us. I endorse completely this group, and particularly Jane and Michelle Frawley from HETI and from ICTN, who were kind enough to give Andrew and I the grant to make this all possible. So we're indebted fully to their kindness and their foresight, and honestly, they've made the whole thing so much easier. We actually got the funding in middle of March, and it's got to be finished by the end of May. So this was a real whirlwind a bit of initiative for us, and we managed to get, and through your goodness and your being here, have made it this far. So I'm indebted to Jane being with us. She drove over to us today, and she's just going to talk quickly about about Hetty and about the HWA. Thank you.
Thanks, Tanya. Thank you. I actually don't have I have a nursing background. I've spent most of my working life working in clinical and teaching positions across regional Western New South Wales. So I'm based in Dubbo and worked out in that area most of my working life. The Western Interdisciplinary Clinical Training Network is one of 8 statewide networks that was established mid last year as part of the health workforce reform for the purpose of improving and facilitating collaborative strategic planning of clinical training at a regional level between local health district, education providers, NGO sectors and the private sector. The ICTNs are part of the HETI, the Health Education and Training Institute. We're funded under HWA. And our Western ICTN takes in, it's the largest of all the networks, and we take in Western Sydney LHD, Nepean Blue Mountains LHD and Western New South Wales LHD. So I'm based out at Dubbo, Michelle's based at Westmead Hospital. And I guess our core functions are promoting access to clinical training placements at a local and regional level, enhancing the relationship between health providers, education providers, both in the public sector and private NGO sector, promoting access to clinical supervision and support projects and funding with HETI, and promoting access to simulated learning environment projects and funding. So the ITCN design allows for a considerable portion of funds to be utilised for or made available for projects that aim to develop innovative models of supervision and training and identify clinical placement opportunities. So that's probably the core aim of where we're heading, hence why we've been able to fund Tanya's project. And I guess not only do I think it's a fabulous project because it's of its interprofessional focus, but it has the potential to be benefiting a broad range of disciplines. And I guess particularly for me, when I look at, I'm pretty passionate about rural and remote learning, so I think it certainly has the potential to be assisting regional, rural and remote clinicians. So there is. Without taking up any more time, there's a flyer out the back there for around the ICTNs, and I really would invite you to join our mailing list. Not only can you be of assistance to us in helping us looking at current and potential clinical placement capacity for students into the future, but we can benefit you as well by providing opportunities for funding for projects such as this one Tanya's overseeing, but also look at funding for clinical supervision, training and support from HETI and all the resources HETI offer, and looking at simulated learning and general project funds to enhance clinical placement. So please put your contact details, I'll leave this down the back, if you just put your contact details on the form, and I will join you to our network. For those that are based in Sydney, not only will you have access to the Western ICTN, but I will also join you to the relevant networks that you might come under, and I suppose that may be some of the metropolitan networks as well. So please give me your details, and I'll certainly have all the, you'll be getting all the resources from HETI and the ICTNs into the future. And please feel free to speak to me during the lunch break if anything, any other information you'd like. Thanks kindly.
Thank you.
Thank you very much, and thank you very much to HETI and HWA for everything today. So I'm pleased and proud to introduce Professor Davidson, who's going to give us his address now.
Thanks, Tanya. Just, Nigel, if you want to give up dentistry, there's always a first year radiography position available. I think you picked it up a little bit quicker than most of my first years, so that's great. We've mentioned the word interprofessional, and I've just heard a little bit about rural and remote, and yesterday I was at a meeting about medicine and interprofessional and rural remote, and the shortage of doctors in regional and remote areas. And we had a Scottish clinician talk to us yesterday. So he's come from an epidemiological background as well, and he gave us a definition of rural and remote in Scotland, and I thought it was quite interesting. If you're within 25 kilometres of a distillery, you're rural. If you're outside of that, you're remote. So I thought that was quite apt. So again, thanks for the invite. What I want to talk about is cone beam radiography, cone beam CT. It's just an example of what we're doing in Charles Sturt University in terms of some of the cross-disciplinary, interdisciplinary research areas. So what I want to do is just to give you a bit of an overview of the school. We're in the School of Dentistry and Health Sciences, and so that's really applicable for today. So a bit of an overview, a bit of the research that's going on, and then just to talk a little bit about some of the actual research project and where that's heading. In terms of CSU, 4 faculties, and we're within the Faculty of Science. So it's the largest faculty in terms of diversity, agriculture and wine science, which is nice. Reference to the distillery, we're the only university to have a winery on campus, and it happens to be at the Wagga campus, so that's again good. Animal veterinary sciences, biomedical sciences, community, environmental health, and nursing, midwifery, Indigenous health, and not last or least, dentistry and health sciences. So that's where we're sitting. So we're sitting in that school, and it's quite an interesting mix. Of course, we have dentistry, which is based on the Orange campus, and we have clinical dental sites at every campus in the university, or every major campus. So it gives opportunity for the dentists and the oral health people to undertake some work. We have medical radiation sciences, so medical imaging, nuclear medicine, radiation therapy has just started up this year, medical sonography, physics, which doesn't quite necessarily fit under medical radiation science, and we're just about to start up astronomy. I'm not quite sure how that one gets in with medical radiation sciences, other than there's a bit of a link between imaging, so that'll be quite interested to see how we go with that. So other areas are nutrition and dietetics, and and oral health. So again, a bit of a mix that's going on between there. So there's some interesting interdisciplinary areas and some opportunities within that. So in terms of the courses or programs, there's the Bachelor of Dental Science. Medical radiation science is by far the largest. We have the most number of students. So we've got a very large program in terms of the Bachelor of Medical Radiation Science. Medical imaging at Wagga, and we've just started that at Port Macquarie as well, so 25 students at Port Macquarie. Nuclear medicine, radiation therapy, both in the Wagga campus. And we've got a very large DE conversion in terms of medical imaging and nuclear medicine. It's got some masters, and so there's some new approach to masters as well, with molecular imaging commenced this year as well. So again, designed at not the physicist or the medical level. It's more at medical radiation science level. And of course, we'll talk to you a little bit about some of the research that's happening within that area. Nutrition and dietetics is undergoing a little bit of a change in terms of the bachelor program is being phased out, and a Masters of Nutrition and Dietetics as a graduate entry approach is being phased in. So that's just currently going on at the moment. So again, creating some interesting opportunities for links between the areas. Oral health is a Bachelor of Oral Health, and Oral health and dentistry have only been around for 5 years. So in dentistry, it's only in the current fifth year dental students are the first ones and will be the first lot of graduates at the end of this year. We've had some oral health graduates. So you can obviously see some of the relevant links between nutrition and dietetics and oral health and even dentistry. And so there are some very good teaching and learning type links that are going on within the school. And there are some outside of the school in terms of some of the other areas as well. So we have a major clinical focus, and obviously that's what today is about, getting some clinical education and being able to understand what's happening within that space. And so there's very well understood links between education, clinical skill development, and Andrew's alluded to some of that this morning, and we think we've got some very good clinical outcomes. We've run a medical imaging program for over 30 years and a bachelor's program for over 20 years. So I think there's a lot we're doing right, and I think there's still a lot we can learn, and there's still a lot we can do to improve and make sure that we get those professional outcomes. I think one of the strong things that we are recognised for is our work-ready students, and that's always been a major focus of CSU. And while maybe there are some students that have got high academic achievement, and we don't necessarily have a major focus on getting them that, what we do have a very strong focus on is beginning practitioners. So I think that is our major strength, and having our staff and Andrew coming in now to be able to drive that even further is going to be an added bonus. Just a brief overview of what we're doing in terms of being able to achieve that is you can see that there's a very significant focus in terms of those 4 years, 2 weeks, 12, 8 weeks, and in the final year, 36 weeks of clinical work. So the steps through that Andrew's been talking about earlier, making sure that we have got competences mapped against those particular levels to make sure that we are evaluating those students at a high level and appropriately. Where I wanted to have a bit more of a focus today was some of the research areas. And a big list here. I'm not going to go through a whole lot of the details. And this is just picking off the website on the major researchers' staff, staff research profiles. You can see that the real focus in here is medical radiations. We've got one researcher who's got nutrition and dietetics background, and there aren't any defined researchers within dentistry and oral health. Sure, there's some people doing some research, but they're not at the level in terms of these new programs for them to be able to spend a lot of time and focus and energy on their research. And I'm sure that's going to be a focus in the coming years, but at the moment the focus is fifth year dental students, first lots of graduates in oral health. And so you can understand that they're coming in, making sure that the program is well established, is heading in the right direction, getting good student outcomes. So the research for the school has primarily been left up to the medical radiation side of things, with medical imaging, nuclear medicine, and the physicists. One of the interesting ones in there is theoretical dark quantum gravitational eigenstates. It's a fantastic thing to have a listen to. Blows me away in terms of what my understanding is. But it doesn't quite fit in with the rest of us, so I'm not quite sure how I'm going to map that in with all of the other clinical outcomes. It's basically the non-clinical focus one, but it's fascinating stuff to learn about all this dark matter and all those sorts of things. But the majority of it, you can see, is around imaging, is around physics, is around medical areas. So there is a lot of focus on that area, but there's nothing inside of the dental or oral health space. yet we have got one student in there. So I thought he was a good example of being able to show what we're doing in terms of the school. So we have an international dentist who's the student undertaking his PhD, and he's undertaking an image quality assessment, low dose multi-slice CT and cone beam CT, and having a look at the protocols in the oral maxillofacial area. So he's having a look at landmarks, and I'll talk a little bit more about that. His principal supervisor is a medical physicist, and me as his secondary supervisor. So just to give you a little bit of a background on his work, so most of you already pretty much understand this, but radiography's been around since 1896 with Röntgen discovering X-radiation, and intraoral radiography took off pretty soon around about that time. So speaking to the dentist, I'm sure you all understand, to get the highest detail in the image, the highest spatial resolution, you really need intraoral radiography. Extraoral radiography doesn't provide that detail that you need, but it gives a really good overview of assessment. And there's some examples of that. OPGs came in around about the 1960s and produced those really good overviews that talk about implants. We were able to provide you with an understanding of what's needed with implants. All of these imaging formats are now moving into the digital arena, and one of the issues that has been around in terms of radiography, whether that's medical radiography or dental radiography, is with film, radiography was then, the dose was limited by the film. It was controlled by the film. The film is the determinant of the dose. If you are under the dose needed, the image quality was not optimal, was poor. If you're over the dose, again, the same sort of area. So you had to make sure that the dose received was appropriate for that particular film recording device. The current digital formats means that there is no dose control. Brightness and contrast, which is required from an optimum dose in film, is now controlled by digital modalities. You're able to control the brightness and contrast of a digital image just like you can with your photography through using things like Photoshop. So this is the issue that we're struggling with in medical radiography, and it's a major area of research that both the medical physicist Xiao Ming and I have got a high interest in. So being able to translate that now into the dental area has got some advantages. Cone beam CT. Well, cone beam CT is the latest modality, and again, dental implants, we were talking about them earlier, really need to have good cone beam CT images to be able to assess your patient prior to having dental implants. So it's been around since the late 1990s, and it's a growing technique. CT's been around since the early or the late 60s, and if you weren't aware, there's a very strong relationship with the Beatles, and they were actually the ones whose money went to support the research from Godfrey Hounsfield. So another interesting thing, just a little bit of interesting information. Cone beam CT is again using a similar process to ordinary CT, being able to rotate a X-ray beam and the detectors 100 or 360 degrees around the patient. Typically here we're talking around a long radiographic exposure time of around 8+ seconds. CT's now down well and truly under half a second. But it's got a lot of advantages still. Similar times to an OPG, but a lot more information being able to be provided from the cone beam CT. So just a bit of some of the principles. In terms of, not sure whether that's working. No, it's not. I thought it might have had a mouse control, but I haven't. In terms of the image on the left is conventional CT. Conventional CT uses a wide beam across the patient. I'll call it in the XY direction, and so it's a fan-shaped beam, and it's got a depth of maybe only a few centimetres. So it used to be controlled in the early days would be one slice. Now we're into multiple CT with multiple slice CT, multiple detectors, and that depth of the slice is now the depth of the beam in the Z direction, or the length of the patient, is getting to in the centimetres range. But it's still obtaining narrow, thin slices. Sure, cone beam CT is doing something similar in terms of narrow beam slices and putting them back together, but it's using a broad beam in not only in the X and Y direction as it rotates around the patient, but also in that Z direction, being able to provide that additional length of coverage. So it's giving that depth in terms of one rotation around the patient to be able to provide a large anatomical coverage in the superior-inferior direction of the patient. Typically, it requires the patient to be sitting, as we've seen earlier, and to be very cooperative and not being able to move within that time. So there are some things about cone beam CT. Cone beam CT doesn't provide the low contrast differences that conventional CT does. It still requires a very good subject contrast in terms of primarily imaging bone. So its focus is in high contrast area, bone primarily, and it's not so good in terms of imaging soft tissue. So the evaluation for soft tissue areas would still need to be able to get into conventional CT, which excels in that area. The other difference between conventional CT and cone beam CT is no matter what conventional CT you scan on, water is given a Hounsfield number or a CT number of 0, and there is a progressive scale in either direction, greater attenuation, greater number. And theoretically, hopefully practically, if we image your liver and you have a lesion in your liver and you are imaged on one CT scan and you go down the road to somebody else's, they will be able to see a change in that lesion from the Hounsfield numbers because it's uniform scale. Cone beam CT doesn't have that. It's got no quantitative relationship between the amount of attenuation and comparison between one company and another company. So there are some differences. It's still a very good means of being able to image bone. It still provides high detail and further detail than other imaging areas such as OPGs, and also be able to provide with some lovely 3D images, as we'll see. And so here's just some examples of the cone beam CT. But if you're having a look at everything within that, it's really looking at the high contrast area. It's looking at bone, it's looking at teeth, and being able to provide a detail in that area where there is high subject contrast. It's not as good at looking at the soft tissue area. So those are some typical images from cone beam CT. Well, the project itself is to really evaluate the differences between cone beam CT and multi-slice CT in terms of image quality and radiation dose by assessing some anatomical structures in the maxillofacial area. So what it's trying to do is to have a look at dose reduction capabilities in terms of and image quality relationships, and so with a digital modality to try and lower the dose while not losing image quality or losing detail that dentists will need to make their clinical assessment. So In doing so, we'll hopefully find a relationship between what is acceptable image quality and what is an appropriate dose for these imaging modalities, and then hopefully to be able to relate that to the clinical area. So far in the literature, I may be proved wrong, but the literature that I have seen so far is showing that there is no consistency in processes to set the dose limits on cone beam CT, to have a look at what is an appropriate dose to achieve an acceptable image quality. So that's where the project is trying to work. So what the student is doing is, rather than relying on human volunteers and then all of the ethical issues that go around irradiating, providing additional amount of radiation to humans, he's going to use 3 types of phantoms. He'll use a dry mandible, and that's just going to be scanned, and hence there's no background, so it's going to be really high contrast in terms of differentiation. So again, that'll be scanned with multi-slice CT and cone beam CT. There are different fields, field of view, so the imaging areas between CT is designed to image the entire human body, whereas cone beam is designed to image a small anatomical region in the human body. So the fields will have to be put together to try and work out the optimum side of that. There'll also be a dry skull, and the dry skull will be placed inside a Perspex box, which will then be filled with a roughly tissue equivalent object, water, to try and increase the amount of beam attenuation to simulate what's going on with the soft tissue of a human head. And then the last one will be a 3M skull phantom, which is a adult skull which is embedded in Perspex, again to try and simulate that soft tissue relationship. So to try and add in those different amounts of attenuation. So we'll have a look at what's going on with those 3 areas. So what we'll be doing is getting, or the student will be doing, is getting some dental experts to come in and view the images to assess the image quality. So, and we'll be looking at comparing the images to see under varying different radiographic factors, and hence the amount of dose to the patient, having a look at some anatomical structures such as some of the mental foramen and mandibular canal, and a few other areas within that. So we've got some structures that experts who are used to viewing these images can compare and contrast. So there'll be at least 2 observers involved. We're trying to get as many as possible to try and increase the validity. And they will be viewing the images more than once, and again separated by a reasonable amount of time, so we can get some evaluation of intra and inter-observer agreement between them. So this is using a process called visual grading analysis. Visual grading analysis has been around and being used quite rigorously. It's an attempt to make an objective assessment more quantifiable. So it's designed to have observers compare images is a preferable way. There is one method of just turning around and saying, looking at a single image alone and saying, I assess the image quality of this landmark at this level. Or there's an alternative method, which is the method I prefer, which is having a reference image and then the observer comparing the evaluated image against the reference image to say the image quality of this particular landmark is greater, lesser, and by how much on some sort of Likert scale. So visual grading analysis is going to be used to have a look at this, and some of the techniques under cone beam CT. This is just one of the manufacturers. Cone beam CT is using a variety of different KVP settings, and within that using a variety of different MA settings. there will be a measure of dose that's involved in that. We'll try and objectify that dose difference between this and conventional CT, multi-slice CT. And just some of the images so far that have been obtained using the skull phantom embedded in Perspex, and we can start to see some of the cone beam type images that are available and some of the measurements that will be undertaken within that to assess cortical thickness on a particular radiographic setting versus another area, to have a look at whether the mandibular canal can be visualised to a greater or lesser extent. Using a multi-slice CT, placing the phantom in a correct anatomical location as you would a human patient, and again using different KVP MA settings to again get different dose settings and have a look at those. And some of the images that have been obtained, you can again, I'm no expert, but there's some ability bottom left to have a look at the mandibular canal, for example, and see whether that's being able to be assessed and compare that through a variety of images. And just some of the other examples that have come back from that area. And this is just a very brief comparison between using one CT and one KVP setting with 80 MAS on the left, 120 in the middle and 320 MAS on the right, and being able to then turn around and we can know that the one on the right is 4 times the dose without even doing a dosimetry measurements. There's a linear relationship between MA and dose. So is the one on the left image quality at an appropriate level to make the assessment needed for dentistry work? That's where we need to be able to go and have a look at. So there's some expected outcomes following this research, and so what we're hoping to be able to achieve is to be able to get a lower radiation dose for the dentistry patients, have a greater knowledge of the dose image quality relationship in dental radiography, and specifically more so in cone beam CT. Hopefully the student will continue, gain his PhD, and he'll bring to dentistry a better understanding of the issues of radiation dose, radiographic exposure factors and image optimisation, and hopefully that's going to be translated through the literature, the dental literature. What supervisors are hoping to gain too, and we're in a learning mode, we learn a lot from our students, will gain a higher level of understanding of the issues in dental imagery and be able to translate those issues into our realm. So it's not just a one-way street, it's not using just us as the experts in imaging for the benefit of dentistry, but it's also being able to bring some of that other knowledge from the dental area. Having a dentist as a student, I've had to learn a lot in terms about the processes that he's been through. I'm learning a lot from him in terms of the requirements for dental imaging. So it's a two-way street. I'm continually learning from my students, and I hope I continually will. So in terms of benefits of integrated research, well, in the undergraduate courses and programs, while we'll have interprofessional education and interprofessional learning, there tends to be a real focus on disciplinary requirements, and yes, we will try and bring multidisciplinary teams together to, in the end, to solve in the medical area a clinical problem for a patient using multidisciplinary teams. And my apologies if there's any medical professional people here, but they tend to be sitting at the top, guiding the rest of the team, and that sometimes translates across in when you have medical students coming into interprofessional education and learning with other students. I don't know, there's that level, whether you want to call it arrogance or whether it's whatever that level is, and that was even brought up at the meeting yesterday, which was quite astounding. The medical profession actually even recognised that level of arrogance that they build into their students. So, but my point is that while there's developed and recognised methods to be able to increase that interprofessional learning, it tends to be at a superficial level and tends to be less of a focus than the discipline-specific knowledge and skill development. And that's understandable for undergraduate students. They're there trying to become a dentist, they're there trying to become a radiographer, they're there trying to become a physiotherapist, whatever. They need to be able to get all of that knowledge and skills to be able to meet professional requirements and get out and practice. And the interprofessional learning side of things tends to be, okay, it's something I have to do, like I have to learn a little bit as a radiographer about psychology. Now, I'm not going to use anything to do with psychology in my career, even though I might have to deal with patients. They don't recognise that, but that's a different area. It tends to be, in my limited experience anyway, tends to be more superficial. Where I think that there is a benefit of the integrated research, though, is it's bringing together people who are already practising in their fields, who are experts, who bring their own specialist knowledge and skills, and they're trying to address an issue. So I know there are teams around there who are doing it, and it happens really well in a lot of other areas to address specific problems. But it's a great example of what's actually occurring. Admittedly, it's only N=1 at the moment, but having a dental student being supervised in medical radiation area. So I think there's a lot of opportunities in terms of being able to bring this multidisciplinary, cross-disciplinary approach to addressing a research problem. And I think that there's benefits in both ways. And hopefully that's just an example of what I can bring that we are actually trying to do. So I'd just like to thank Dr. Ahmed Ali, who's the student, and Dr. Xiaoming Zhen, who's the principal supervisor, and also just the staff and research students in our school who are working actively along these sorts of problems. So thank you. Yes.
Are general dentists refundable for Medicare when they ask for the cone beam CT, but they're looking for things like abscess or other soft tissue lesions? We do the slice CT, but then Medicare seems to have a problem refunding from the dentist referral. Is that a problem?
I'm not a clinician, so I haven't got any particular expertise in that area. I'm sorry. I'm happy to somebody else to answer that.
Yes, there's a big problem. Malcolm Coombs, who should have been here today, he's qualified as a specialist max fax radiologist, and he's sort of fighting the Medicare people at the moment because they're saying we can only get a refund if a medical radiologist reports on the films, not if a dentist reports on the films.
So even with a medical radiologist, which we have,
if they report on the film, you can get a Medicare rebate. But if a dentist reports on the film, you can't get a Medicare rebate.
oh, that's really good. Thanks for that.
Mm.
Okay, because I've got dentists referring to me left, right and centre, but we have this problem.
Yes, because at Sydney Dental Hospital, I brought this in some years ago so we could get some money into the radiology department. Our panoramics, and I think cone beams now, are sent to Concord from medical radiologists to report on the film. They then get a Medicare rebate and Sydney Dental Hospital gets part of that rebate. Now the problem is the medical report often says see teeth, or they'll report on the possible abscess at the base of the lower premolar, which is the mental foramen. So they're not very accurate reports. But it's a money thing. It's simply a money thing. Yeah.
Well, yeah, no, some of them did go down that road, but we're actually doing better comprehensive reports
Yeah.
now. So,
Yeah.
oh, that's fantastic. Thank you.
Okay, thanks.
Okay, thank you very much.
Thanks, Sonia.
Okay, so we're running very well. I commend all the speakers on keeping to time. This is lovely. Now, I'll just open up Natalie's as she comes to the desk here. There we go. It's my privilege to introduce Natalie Charlton we're hovering from different universities. We go back to Sydney now. And work integrated learning is a pedagogy that you are, believe it or not, working within. And I think we need to hear about this pedagogy, and certainly from somebody who is deeply in its research, in the throes of its research. So I welcome Natalie to the bench.
Okay. Thanks, Tanya and Andrew, for having me. I've got a bit of a hard act to follow now after all of those talks. And I was sitting here looking at my presentation thinking, I don't have all these great pictures of puppies and other things in here. What my role is at Sydney Uni is we have moved from having a clinical and professional fieldwork team, which is what Andrew did work with us in before he moved to Charles Sturt. And at the start of 2012, we moved to a work integrated learning team. So what my role is to manage the work integrated learning clinical placements for our radiography students, nuclear medicine and radiation therapy. So I look after all of MRS. So, which is actually quite a lot of work, but that's okay. So, I think I've got something like 450 students now, but anyway. So what this is about today, and you're going to find some of the things I'm talking about have been mentioned briefly by Andrew and also by, was it Jane from HW, from Hetty that was here? So what we're going to look at is what actually is work integrated learning, what is the structure of work integrated learning, then having a look at work integrated learning specifically in the Faculty of Health Sciences at Sydney Uni, the government importance of WIL, because a lot of what we are talking about today, and you're hearing all these things about HETI and ICTN and HWA, a lot of the changes that the universities have made and the shifts that we've made have been in direct response to all of these government reports and studies that have been happening. And then having a look at drawing that all together and saying what impact does that have on all of us as clinical educators and clinical supervisors. Because it's one thing for us to stand here and talk about all of these things, but then we have to put it into context of what does that mean for us in our practice of having students. So, with work integrated learning, I've put a couple of definitions up here so that I can then talk to you about it a bit more and give you an understanding of the perspective that I'm coming from today with this. So basically, what a lot of the literature is describing WIL as is it's a term which describes a range of approaches which integrate theory with the practice of work within a purposefully designed curriculum. And then there are some others that are saying it's a deliberate and intentional learning in work. So the students are trying to actively learn something. It's supported by appropriate induction of students and supervisors and imaginatively embedded assessment. So for us, as clinical educators in radiography and in dentistry, the most common form of WIL that we experience is a clinical placement. So you are going to have students that are enrolled in a university program, either in dentistry or radiography, and are coming out to see you for a clinical placement at some particular stage of their degree. Now, for dentistry, forgive me if I say this wrong because I know you guys have your dental schools and it's a little bit different. So it's part of a professional entry program, so it's part of a clinical unit or a professional practice unit. The student is given the opportunity to apply the theory that they've learned at uni into the clinical practice environment. What we're trying to do here is promote a deep approach to learning, which is something Andrew was touching on earlier. What we're interested in the student actually achieving is we want them to make deep connections between what we've taught them at uni and then what they're doing with you in clinical practice and what they're seeing in clinical practice. Because we are trying to create a practitioner who is a holistic practitioner, who can look at a patient problem or a patient issue or a case and apply critical thinking skills, problem-solving skills, clinical reasoning, lifelong learning, lateral thinking. One of the first things I always say to all of my students, and Andrew did touch on this earlier, he and I have worked together, I think, for so long, we think quite alike. But I will say to them, you can't have every patient present exactly the same way. I'm a radiation therapist by background. I have so many students that say to me, oh, this is how you taught me how to plan a prostate. So I went out on clinical placement and I wanted to plan it that way and it didn't work. And I said, well, not every patient fits into this lovely, nice little neat box that we all want. It just doesn't happen. So what we're trying to do is get them to understand why they're doing what they're doing. Not necessarily these are the steps. So what we're always saying to them, I say to my students, I can teach you the steps of a chest x-ray. I can teach you the steps of giving a patient brain treatment. It's very, very simple. But there's a whole lot of other things that go into it as well that they need to think of. What we also are looking at here, and this comes into the definition that is here, is actually developing new ways of assessing students. So using best practice, educational theory. And one of the things you're going to be hearing about this afternoon, the radiographers in the group with Andrew, is the brilliant work that he is doing as part of his PhD in developing a new national diagnostic radiography clinical assessment tool for us to be able to more accurately assess a student's performance on clinical placement, to really take into account all of the things Andrew was talking about in his talk this morning about the issues around assessment. The other thing as well is looking at assessment tasks that we are giving students while they're on clinical placement to complete, which are actually promoting deep learning. So it's not something like just ticking a box, and the student goes out and does a competency and says, right, I can do a chest x-ray now, I've had all these boxes ticked and that's it. It's about more than that. It's about us coming up with how can they demonstrate that they have all of the required skills that you want them to have to then be able to work. So there's a lot of that comes into it about, why you're doing what you're doing. Now, the work integrated learning experience or the clinical placement experience, it's not enough for us at the university just to say to a student and to you, here's everything you need for your placement, go out there, have a good time. Which, there has been instances of that happening before. What the work integrated learning experience is about is adequate support and preparation of both the student and the clinical educator for that placement. So at the university level, what we are doing is actually supporting the student by giving them adequate briefings beforehand, giving them all of the information they need about the expectations of the placement, what their professionalism expectations are, and at the same time also providing support to clinical educators in the form of workshops, which I'll talk about in the last part, where I'm going to talk to you about things that are available, grants, etc., to help you with your teaching. But it is, and Charles Sturt do it as well. Andrew told me that he was out visiting some educators earlier on this week doing an IPE workshop. So it's about us providing you with knowledge that you can use to assist you in your role as a clinical educator and to give you the strategies for appropriate supervision. And the other part that comes into that as well when we're talking about appropriate induction of students and supervisors is the induction of the student to the clinical placement itself. So when they arrive on day one to you, what we're talking about here is the clinical site actually providing the student with some form of orientation on day one of the placement. So, and we've got some clinical sites that'll spend a day with the student on orientation and others that will spend a morning. It's not the length of time that is important, it's the content that's going into that and what you're actually doing in that induction. So a lot of clinical educators, and probably the majority of you are already doing this,